Welcome to the deep dive. Today, we're tackling a really intriguing, though thankfully not very common, condition affecting blood vessels. Spontaneous, isolated visceral artery dissection, SIVAD for short.
Right.
And we're specifically going to zero in on the mesenteric arteries. Those are the ones feeding your intestines.
Exactly. And, it's important to say up front, this isn't like an aortic dissection where the main artery tears.
Okay.
And it's usually not linked to those connective tissue disorders like Marfan syndrome that some people might know about. This is different. A tear just sort of happens spontaneously in one of those gut arteries.
Spontaneously. Wow. Okay, and to get into this, we're leaning on some top-tier sources, chapters from Rutherford's Vascular Surgery and Endovascular Therapy, the latest, 10th edition.
Solid stuff.
So our mission today really is to get a clearer handle on SIVAD. Why are we seeing more reports now? What might be causing it? How do people, present?
And how do we treat it? Because, spoiler alert, since it's rare, there isn't one single agreed-upon treatment path. It's complex.
Right, no clear guidelines. And that rise in reported cases you mentioned, that's fascinating. Is it actually becoming more common?
Well, that's the interesting part. It looks like it, but the thinking is it's mostly down to how much better our imaging has gotten.
Ah, okay, like CT scans.
Exactly. Abdominal CTs are everywhere now. We're just spotting these things much, much more often than we could, say, 20 or 30 years ago. Plus, doctors are more aware it exists, so they look for it.
So better detection, not necessarily a SIVAD epidemic.
Precisely. It highlights how technology changes what we see in medicine. We're diagnosing things we used to miss.
Okay, that makes sense. Let's dive into the details then. Incidence first, how often does this happen and which arteries are the usual suspects?
The superior mesenteric artery, the SMA, is definitely number one. That's the most common site for these visceral artery dissections.
The SMA, got it.
After that, the celiac artery is the next most frequent.
And the numbers really tell a story, don't they? I saw that before 2001, there were only about 46 documented cases of CIVAD. That's the SMA version.
Yeah, just 46 in all the literature.
But by 2016, over 622. That's a huge jump.
It's massive.
Yeah.
Really underlines that detection point we were just making.
So SMA is most common, celiac next. What about getting it in both at the same time?
That's really rare. Spontaneous isolated celiac artery dissection, CIVAD, is less common overall, and getting both CIVAD and CIVAD together. Very unusual. One review found only 13 cases like that reported up to 2008.
Okay. And it's not just the SMA and celiac, right? Other arteries can be involved too.
Correct. We see it occasionally in the splenic artery, going to the spleen, the hepatic artery to the liver, the middle colic artery, even the inferior mesenteric artery. But yeah, much less often than the big two, the SMA and celiac.
Is there a typical patient profile? Like, are certain groups more likely to get CIVAD?
Well, there seems to be a male predominance. Reports vary, but somewhere between, say, 67% and maybe up to 88% of cases are in men.
Interesting.
And usually folks in their 50s or 60s.
Yeah.
That fifth to sixth decade seems to be the most common time for it to appear.
Okay. And what about risk factors we associate with other artery problems, like high blood pressure? Is that a big factor here?
That's another kind of interesting point. With aortic dissection, high blood pressure, hypertension is super common. Like 60–70% of patients have it.
Right.
But with these isolated visceral dissections, it's less common, more like 30–40%.
Right.
Still a factor for some, but not as strong a link as you see with the aorta.
And you mentioned geography earlier. Where are most cases reported?
Yeah, that's quite striking. The vast majority really come from East Asian countries. Korea, China, Japan.
Huh. Why might that be?
Well, it does raise the question of a possible genetic predisposition in those populations. It's a noticeable cluster.
Okay, so we know a bit about who gets it and where, but the million-dollar question, why does it happen? What's the cause?
The etiology. Yeah, that's where it gets a bit murky. There's no single smoking gun, unfortunately.
Multiple theories, then?
Exactly. Several ideas are floating around, and the cause might even be different depending on which artery we're talking about, SMA versus celiac.
Okay, lay some of those theories on us. Are there links to other conditions people might have heard of?
There are some potential links, things like connective tissue diseases, Marfan, Ehlers-Danlos, Loeys-Dietz.
Right, the usual suspects for artery issues.
Kind of. Also maybe cystic medial necrosis, segmental arterial medialysis, SAM. We might come back to that. Beset disease, fibromuscular dysplasia, or FMD. And this is really key.
Okay.
Most people who get SIVAD do not have any of these underlying conditions. The vast majority don't. So these aren't the main explanation for most cases.
So maybe a factor for a few, but not the driving force for most people with SIVAD.
Precisely. Other things have been suggested too, more general risk factors like tobacco use, atherosclerosis, maybe heavy alcohol use, obesity,
Mm.
even things like heavy weightlifting or pregnancy, possibly due to increased abdominal pressure.
But if it's not usually those conditions or obvious risk factors, what's the leading idea, especially for the SMA, the most common one?
The main theory for CISMA, the SMA dissection, revolves around its anatomy. The tear usually happens about 1 to 3 centimeters from where the SMA branches off the aorta.
Okay, near the origin.
Right, and right there the artery changes. It goes from being pretty fixed in place behind the pancreas to be much more mobile as it enters the mesentery, that tissue holding the intestines.
Ah, I can picture that, a transition point.
Exactly. And the thought is that this transition point experiences a lot more mechanical stress,
Yeah.
hyperdynamic forces, increased shear stress from the blood flow. It just makes that spot vulnerable.
Like a hinge point almost.
Sort of, yeah. Flow dynamic studies actually show the highest stress is on the front curve of the SMA right after it comes off the aorta. The idea is this repetitive mechanical stress is more likely the culprit in most people than, say, fundamental weakness in the artery wall or just high blood pressure.
That makes intuitive sense. Like you said before, almost like a type 2 aortic dissection near the ligamentum arteriosum, another transition zone.
That's a good parallel, yeah. Now, there is another hypothesis, too,
Which is,
that maybe it starts with bleeding inside the artery wall itself. A rupture of the tiny blood vessels that feed the artery wall, the vasa vasorum. That bleed could then split the layers.
so an inside-out problem rather than just external stress. Interesting. And the genetics. You mentioned the East Asian link. Any specifics?
There has been some research pointing to a specific spot on chromosome 5 locus 5q13.14.
Okay.
And that same area has been linked to familial aortic aneurysms and dissections. So it suggests maybe some shared genetic susceptibility pathway.
And the celiac artery. Same theories apply, or is that different?
It's less clear for CIVAD, the celiac dissection. One idea involved the median arcuate ligament, a muscle band that crosses over the celiac artery.
Right, sometimes associated with compression syndrome.
Yeah, the thought was maybe that ligament causes chronic stress leading to dissection, but honestly, the evidence hasn't really panned out to support that as a common cause. So why CIVAD happens is still more of an open question.
More puzzle pieces needed there. When they do look at the artery tissue itself in SIVAD cases, what do they typically find?
Well, they often see things like fragmentation of the elastic fibers, loss of smooth muscle cells, maybe some myxoid degeneration that's like a weakening of the structure, sometimes atherosclerotic changes, but usually there's no clear sign of a specific underlying artery disease or arteriopathy. It often looks like an isolated event in an otherwise relatively normal artery for that person's age.
Right, so not necessarily a sign of widespread vascular disease for most folks. Okay, let's shift to how this actually presents. What does it look like clinically?
It's incredibly variable. I mean, it can range from being a total surprise finding on a scan done for something else.
An incidental finding.
Exactly. All the way to causing serious bowel ischemia, lack of blood flow, or even forming an aneurysm that might rupture. A whole spectrum.
Wow. How often is it actually found incidentally without symptoms?
More often than you might think, especially now with CT and CTA being used so much.
Yeah.
Some studies report up to a third of SIVAD cases are picked up this way, totally by chance.
Assured. Okay. But for those who do have symptoms, what's the main complaint?
Abdominal pain. That's the big one. Around 90% of symptomatic patients report pain.
What kind of pain?
Often described as really severe, sometimes tearing, usually in the upper middle abdomen, the mid-epigastric area, and it might radiate through to the back.
Sounds pretty dramatic. Any other common symptoms?
Yeah, people might also have nausea, vomiting, maybe melena, that's the dark tarry stool, suggesting upper GI bleeding or diarrhea.
And if it is causing bowel ischemia, how does that pain present?
Yeah, that's where you get the classic pain out of proportion to physical findings. If someone is writhing in agony, but their abdomen isn't particularly tender when the doctor examines it, that's a huge red flag for mesenteric ischemia.
Okay, a critical clue.
Definitely. And CIVAD could be the reason for that ischemia.
So what if there's pain, but no clear signs of ischemia? What's causing the pain then?
Well, the dissection itself can cause inflammation in the tissues and nerves around the artery, the visceral nerve plexus. That inflammation can be painful. Some research even suggests longer dissections might cause more inflammation and thus more pain. But you have to be careful. Pain that just won't quit is more likely due to ongoing ischemia.
So again, really variable, no symptoms, Severe pain, ischemia, maybe just inflammation. It must make diagnosis tricky.
Absolutely. That variability is a major challenge both for diagnosis and for figuring out the best treatment approach.
Let's talk diagnosis then. Are there specific blood tests?
Not really, no. There's no magic blood test for CIVAD. Now, if there is significant bowel ischemia, you might see an elevated lactate level.
Okay, a sign of poor perfusion.
Right. And sometimes, even without definite ischemia, you might see inflammatory markers go up, white blood cell count, C-reactive protein, ESR. But those are very nonspecific. Lots of things can cause that.
So blood tests are supportive at best. Imaging must be key.
Totally. It's all about the imaging. Think about it. Historically, before the mid-70s, CIVAD was mostly diagnosed at autopsy.
Wow.
The first reported case, back in 1947, ended in bowel infarction and death. The first documented survivor wasn't until 1992. It really shows how limited diagnosis was.
Incredible progress since then. How did imaging evolve?
Well, angiography got better with digital subtraction angiography, DSA. It was better than old-school X-ray angiograms for seeing smaller vessels. But it's still invasive, requires catheters in the arteries, and it doesn't show the artery wall or surrounding tissues as well as CT.
So the current gold standard is?
Contrast-enhanced CT and CT angiography, CTA, hands down. These days, CT or CTA diagnosis is probably over 95% of CIVAD cases.
And what can it show?
Everything you need to see, really. The tear itself, the intimal flap, the false lumen that channel blood flows through on the wall, whether there's a re-entry tear further down, any blood clots or thrombus, bleeding within the wall, intramural hematoma, aneurysm formation.
Even rupture.
Wow, very detailed. Yeah, and sometimes even subtle signs, like increased density in the fat around the mesenteric arteries. Mesenteric fat stranding can be a clue. CT gives you the location, the extent, everything.
What about ultrasound or MRI? Do they play a role?
Duplex ultrasound, or DU, can be useful. It's non-invasive, readily available, but it can be tricky to see the dissection flap clearly, especially if the false lumen is clotted. And things like bowel gas or obesity can make it hard to get good views.
Right, limitations.
MRA, magnetic resonance angiography, can also show dissections, but it's generally slower, less available acutely, and maybe not quite as detailed as CT for this specific problem. So CT and CTA really reign supreme.
Okay, CT-CTA it is. Now, I understand doctors use different classification systems for these dissections. Why bother classifying them? What's the point?
Good question. The idea behind these systems is to try and standardize how we describe the dissection, which might help predict the risk. Is this one likely to cause problems? And potentially guide treatment decisions.
Yeah.
They look at the type of tear, how far it extends, things like that.
Makes sense. Let's go through a couple. There's one by Sakamoto from 2007.
Yeah, that was one of the earlier ones based on CT findings. It had 4 types. Type 1, the false lumen is open, patent, and has both an entry and a re-entry tear.
All right, blood flows through.
Type 2, the false lumen is open, but it's a dead end, a cul-de-sac.
Yeah.
Has an entry tear, but no re-entry.
Got it.
Type 3, the false lumen is clotted, thrombosed, but there's an ulcer-like defect visible. And type 4, the false lumen is completely thrombosed, clotted off with no ulcer.
Did Sakamoto find any patterns based on these types? Like, were some riskier?
In their initial group, they suggested type I often did okay with conservative management. Type 2 needed closer watching because that dead-end false lumen could potentially compress the true lumen.
Right, cut off flow.
Type 3 actually had the highest rate of needing intervention in their series. And type 4, the fully clotted ones, generally didn't need immediate treatment, but, it is criticized a bit, didn't include complete blockages, small sample size.
Okay. Then there's the Yun classification. You said that one's used quite a bit.
Yeah, Yun's is probably the most commonly cited, partly because it's simpler. It has 3 main types.
Yeah.
Type I is like Sakamoto's type 1, open true and false lumens, entry and re-entry.
Okay.
Type 2 is split. 2I has an open false lumen but no re-entry, like Sakamoto II. Type I also have no re-entry, but the false lumen is thrombosed, clotted.
And
Type 3 in the Yun system is when the dissection leads to complete occlusion blockage of the SMA.
Did this system help predict outcomes or guide treatment any better?
Well, in their study, they did find that how bad the pain was seemed to correlate with how long the dissection was.
Interesting.
But again, with only 32 patients, they couldn't really say this type needs X treatment or that type predicts Y outcome. It just wasn't powered for that.
Right.
But its simplicity has made it popular.
Simpler is sometimes easier to use day to day. Were there others that tried to be more complex?
Yes. Zerbib and colleagues added more types, building on Sakamoto. They added types for aneurysmal dissections with downstream narrowing and specific types for total or partial SMA thrombosis.
Did that help?
They also found certain types seemed to need more interventions, but again, it didn't really predict the overall clinical course reliably.
And there was one based on location, Luan and Leak.
Right. Their system focused on where the dissection was and how far it went. Type A went right up to the origin. Type B was just in the curve. Type C went further down but spared certain branches. Type D extended into the branches, feeding the ileum and colon.
And did location matter for symptoms or treatment?
They found type B, the ones just in the curve, were less likely to be symptomatic. Type G, extending way down, had more severe pain. But again, tiny sample size, only 20 patients. Hard to draw firm conclusions, though type B seemed to do well with conservative care.
So it sounds like multiple attempts to classify, but no single winner emerged.
That's pretty much it. Lots of systems proposed, but none have really become the universal standard or dramatically changed management. And importantly, most of these focus only on the SMA, not the other visceral arteries. There's still no widely accepted, clear-cut algorithm.
Which brings us to treatment. Given the lack of a standard classification and the rarity, how do doctors decide what to do?
It really comes down to the individual patient. You have to look at the specifics of the dissection on the scan, what symptoms the patient has, and how things are changing over time.
Right, personalized medicine.
Exactly. And as we said, the rarity means we don't have huge clinical trials telling us definitively what's best. But the good news is, as we've gotten better at diagnosing it, we've also gotten better at different treatment options, both medical and interventional.
Let's break that down. What about patients who have CIVAD found, incidentally, no symptoms?
For the asymptomatic patient, the general agreement is medical management. Basically, watch and wait, manage blood pressure, maybe cholesterol.
Makes sense. Do they use blood thinners or antiplatelets?
That's actually a gray area. The role of antiplatelets like aspirin or anticoagulants isn't really clear-cut, whether the patient is asymptomatic or symptomatic. There's no strong consensus.
Okay. Now for the symptomatic patients, the ones with that abdominal pain.
Right, the majority present with pain. And that pain, remember, could be from the inflammation of the dissection itself, or it could be from ischemia, reduced blood flow.
So how do you approach them?
Well, everyone agrees if it's just an incidental finding, no major aneurysm, no symptoms, intervention isn't usually needed. The debate is really around the symptomatic folks. And predicting if ischemic symptoms will stick around is tough because everyone's collateral blood supply is different.
So what's the first step typically for someone with pain?
Usually bowel rest MPO, nothing by mouth and close observation, especially if their lactate is normal, white count isn't crazy high.
Give the gut a rest.
Exactly. If the pain continues, sometimes parenteral nutrition, IV feeding is used. The hope is the pain settles down as maybe collaterals open up or the dissection itself stabilizes. But remember, inflammatory pain can linger for days too.
What about those blood thinners here in symptomatic patients?
It's again controversial. Anticoagulation has been used quite a bit, often short-term. But some recent reports are questioning if it actually helps much, or if it might even increase risks in some cases.
So can you manage symptomatic patients just with medication without surgery or stents?
Yes, absolutely, as long as there's no active bleeding. The first report of successful medical management was back in 1994. Some series show good results, even remodeling of the artery, with just conservative care.
But, I sense a but.
But there are also contrasting reports. Patients managed conservatively who then got worse, progressed, and even had fatal bowel infarction. So it's not without risk and requires very close monitoring.
A balancing act. Overall, though, is medical management successful often?
Looking at the reports in the last couple of decades, yes. The majority of CIVAD cases, including some CCAD, seem to be managed successfully medically.
And what happens long-term for those patients? Meds, follow-up.
If symptoms resolve and they can eat normally, definite radiographic follow-up is needed to keep an eye on the dissection. As for long-term blood thinners or antiplatelets, if no intervention was done, there's no set rule. Many recent reports don't use long-term anticoagulation, and some even avoid antiplatelets.
Okay. So when does surgery come into play? When is medical management not enough?
Historically, surgery was reported more often, especially early on. The first successful surgery, that bypass in '92, was for ischemia. Open surgery is still the go-to if there's active bleeding in the abdomen or if the bowel ischemia is really advanced, threatening bowel viability.
What kind of surgery do they do?
Options include resecting any dead bowel, trying a direct repair of the artery tear, sometimes ligating or tying off the artery if collateral flow is good enough, or doing bypass grafts, either from the aorta or from another artery. Sometimes they might clean out the inner lining, an entomectomy, and put a patch on, often using the patient's own leg vein, the saphenous vein, for grafts.
Got it. Now, what about the less invasive options, endovascular treatments?
Yeah, endovascular techniques are playing a much bigger role now. Things done via catheters.
Like what?
Well, thrombolysis clot-busting drugs is pretty rare for CIVAD. Mixed results, usually combined with stenting if used. Embolization, using coils or plugs to block off areas, can be good for aneurysms that form, or if the false lumen ruptures. Coil embolization has worked well in some
This
cases.
is the big one. Stenting.
Right. Stenting is becoming more common. First report was back in 2000. The main reason to stent is usually ongoing abdominal pain that you think is coming from the dissection itself, not necessarily critical ischemia.
So the goal is to stabilize the artery.
Exactly. Eliminate any significant narrowing, stabilize the vessel wall, maybe prevent aneurysm formation down the line.
Are there downsides to stenting compared to open surgery?
The main one is you can't directly look at the bowel like you can in open surgery to see if it's healthy or ischemic. That's why stenting is mostly used for patients with pain, but not necessarily full-blown bowel emergency.
Okay. Is there a threshold? Like, when do they decide to stent?
Some suggest stenting if the true lumen is narrowed by more than, say, 80%, or if the artery starts ballooning out, dilating over 2 centimeters, but even that's debated, because sometimes things improve medically.
How do they technically place these stents?
Usually through the femoral artery in the groin. Sometimes the brachial artery in the arm gives a better angle for the SMA. Getting the wire into the true lumen past the tear can be tricky sometimes.
What kind of stents?
Usually self-expanding stents, often bare metal ones, to keep side branches open. Covered stents might be used for aneurysms, but you risk covering branches. They often stent the whole length of the dissection. There's also newer stuff like flow-diverting stents being used for aneurysmal changes.
And how well do these stents hold up long term?
Data is still limited given the rarity, but so far results look pretty good. Low rates of complications or failures reported. Intermediate-term patency seems high. Long-term antiplatelet therapy is usually recommended after stenting.
Is this mostly for SMA dissections or other arteries too?
Most of the published experience is definitely with CIVAD. There are reports of successful endovascular and surgical treatment for CIVAD and others, but it's less well documented. Identifying the exact branch involved in celiac dissection can sometimes be tricky too.
Okay. Before we wrap up treatment, you mentioned SAM earlier, segmental arterial mediolysis. How does that fit in?
Right, Sam. It's a different beast, really. It's non-inflammatory, affects artery walls. You tend to see aneurysms more often than dissections, often multiple lesions in different arteries, like renal and visceral.
And the presentation is different.
Yeah, with SAM, intra-abdominal bleeding seems more common than clotting issues. Treatment might involve emergent surgery, but endovascular techniques like coiling and stenting are increasingly used for SAM too. It's just important to distinguish it from typical CIVAD.
Good distinction. Okay, so after treatment, whatever it is, what about follow-up? Surveillance?
There's no official guideline, but yeah, most clinicians recommend regular follow-up imaging,
Why? What are they looking for?
mainly to watch for delayed aneurysm formation. We don't really know the true risk, but it's a theoretical concern.
And what imaging do they use?
CTA is generally preferred. Duplex ultrasound is also an option sometimes.
Is there a typical schedule?
A commonly suggested one is maybe imaging at 1 month post-CIVAD, then every 6 months for the first year, then maybe annually after that. But it's based more on expert opinion than hard data right now.
And what does this surveillance show? Did the dissections usually get worse?
Actually, no. What's interesting is that surveillance shows many arteries tend to remodel, they heal or improve over time more often than they form aneurysms.
Really? They can heal on their own?
Yeah, one study showed 41% of medically treated CIVADs improved on follow-up scans and 15% in complete remodeling looked normal again.
Wow. Any predictors for that?
It seems Yun type 2 lesions, the ones with a single tear, no re-entry, where the false lumen clots off, might be more likely to remodel completely.
Does that mean better outcomes?
We don't know for sure if radiographic remodeling equals better long-term clinical outcomes, but importantly, there aren't reports of people having late problems if their dissection was seen to be improving on scans. So improvement seems like a good sign.
Okay, that's encouraging. So let's try to summarize the key takeaways from this deep dive into CIVAD.
Right. So CIVAD is rare, but we're definitely recognizing it more. Mostly affects visceral arteries, especially the SMA. While serious things like bowel ischemia and bleeding can happen, it seems the majority of cases can actually be managed medically with close watching.
and when intervention is needed.
Endovascular treatment, especially stenting, is playing a much bigger role, particularly for ongoing symptoms, and the results so far look promising. Open surgery still has its place for emergencies like rupture or advanced ischemia.
And surveillance is key.
Absolutely. Regardless of how it's initially treated, follow-up imaging seems important to monitor for changes, particularly aneurysm formation, although remodeling seems quite common too.
Okay, so a final thought then for our listeners to chew on. Given everything we've discussed, the increased recognition, the variability, the evolving treatments, what's the next big step needed for CIVAD?
That's the key question, isn't it? I mean, how do we move towards clear guidelines? We need more research, probably multi-center registries, given the rarity, to really understand the natural history better.
And maybe figure out who really needs intervention versus who will do fine with medical management.
Exactly. Can we better predict which patients are at higher risk? Who will remodel? Who might develop an aneurysm? Those are the critical questions we need answers to really optimize care for this really quite fascinating condition.
It really highlights how medicine keeps evolving, especially with these less common diagnoses. Well, thanks for walking us through that complex topic.
My pleasure. It's definitely an area to keep watching.
And thanks to you for joining us on the deep dive.